引き続きバイデケア社のクリス・ダフランテス先生による EGIO の医学的有用性についてお話しいただきます。
Greetings, Dr. Chris Devlantes. I'm an emergency medicine physician in Kansas, and I'm assistant clinical professor of emergency medicine at the University of Kansas. I'm also the medical director for VitaCare, the maker of the EasyIO. So I am biased a little bit about IO access and the EasyIO, but I'm happy to see that the presenter before me gave you all of the research and data about all of the other devices on the market right now for establishing IO access. So I want to talk about, you saw some of these slides previously about how and where to put the IO in the patient. Who needs an IO line? Some of us as physicians may ask ourselves, why would I need an IO? Basically, any time a patient needs vascular access in an emergency, when you can't get an IV peripherally or you don't have time to put a central line in emergency cases. So what are our options? We have a peripheral IV, of course. Sometimes it may take time to do this. Medicines may be given sublingual, intramuscularly, intranasally, or rectally. Obviously, these are not very useful in the acute setting when someone is critically ill. Venous cut-downs are not done as frequently in the United States. I'm not sure about here, but it's something that is time-consuming. And the external jugular may be an option. Central lines have their place, and oftentimes this is what is necessary for a patient who is very ill, but it will take time to establish the central venous line. And intraosseous line should be in our armamentarium. It's something, as emergency physicians, we should think about early on to try to resuscitate patients, and it's something we should consider not as a last resort, and not only in cardiac arrest, but anytime a patient needs to be resuscitated who's critically ill. So the indications are very frequent, something that you might see every day in your emergency department that you might not think about. People come in with septic shock who need vascular access right away. They need to have fluid resuscitation very quickly before we start giving vasopressors. Patients in trauma, blunt trauma or penetrating trauma, severe burns, severe dehydration, anaphylaxis, postpartum hemorrhage, cardiac arrest, of course, dysrhythmias, myocardial infarction. You can have neurologic problems like status epilepticus, where you need to give an anticonvulsant to a patient very quickly. And so these are all just examples of situations where you might use IO access. In my practice, I've used it many times when a patient needs an airway. I need to give rapid sequence intubation drugs to establish an airway, and if I don't have an IV, I cannot give that patient the drugs they need to paralyze them to establish an endotracheal airway. So this is something very frequently I've done in patients with respiratory failure. Therapeutic hypothermia has also been done using an IO device in the pre-hospital setting in the United States very frequently after return of spontaneous circulation and cardiac arrest. Contraindications are very intuitive, so basically if you have a prosthetic limb or a scar on the knee, you assume the patient has a knee replacement, you cannot use that side. Any fracture along the bone, so even an ankle fracture is a contraindication, even in using the proximal tibia. So any fracture along the bone, if you have difficulty finding the landmarks, either because it's a very small infant or a very obese patient, local infection, obviously you don't want to put an IO in an area that has active cellulitis. And if there's been a recent IO attempt in the same bone within 48 hours, you want to avoid attempting to put an IO in the same bone. There are several FDA-approved sites of insertion in the United States, and we usually put them in the proximal humerus, the proximal tibia, or the distal tibia. In Europe and other parts of the world, they're also using the distal femur, and this is very helpful in the small pediatric patient in whom the proximal tibia is not large enough, or you cannot feel the landmarks of the proximal humerus. This is the anatomy of the tibia, and the reason this works is because the proximal and distal ends of the long bones are very vascular areas. The spongy bone contains thousands of blood vessels that will feed into the central circulation. This is a cross-section of an IO needle into the bone, and this is proximal tibia. These gaps in the bone, all this spongy bone, is filled with vascular channels. Thousands of blood vessels. It's a very, very vascular area. And I want you to see how big of a target this is. One thing to keep in mind when you have an IO line is to make sure you flush the saline very rapidly, to flush out the fibrin and the bone marrow in this marrow space in order to establish good flow rates. The proximal humerus is something that some clinicians are not very familiar with, and we're finding more and more that this is really the site of choice. It's a site of choice for many reasons. Anatomically, it's a very large area, and there's nothing to worry about injuring there. The only thing you have to avoid is the bicipital groove where the biceps tendon crosses. There's no major vascular structure or nerve injury that can be that you need to worry about when you're establishing an IO in the proximal humerus. So this is something that you should all become familiar with. It may be a very good option. In fact, in my practice, it's my first option for IO. I use the proximal tibia and distal tibia as a second and third option. The surgical neck is the landmark you're looking for. So when you feel the surgical neck, you go one finger breadth above this and you go perpendicular to the skin at that point. The surgical neck is very easy to feel on most people. It's just a little bit of a speed bump that you feel. It's basically a little ridge right where the shaft of the humerus meets the humeral head. So that the anatomy is very easy to find. As I mentioned, the benefits of the humerus are it's a very large target area. It's very difficult to miss. It's a non-weight-bearing bone, so unlike the tibia, it's very easy to penetrate the IO needle into the proximal humerus because the cortex is thinner. Faster drug delivery. Anything that goes into the humerus gets to the heart within 2 seconds. In pharmacokinetic studies, peak drug concentration in the heart through the proximal humerus was identical to that of a subclavian central line. Likewise, a proximal tibial IO reached the heart in 6 to 10 seconds and is equivalent to a femoral central line. The flow rates of the humerus are much higher than the tibia. You can get on average 5 liters an hour through the proximal humerus. In the tibia, you may only get about 1 or 2 liters an hour on average. So one more benefit of the humerus over the tibia. So if you have someone in shock who needs a lot of IV fluid resuscitation or needs blood products and volume, the humerus is much better. The other benefit is because it's a larger bone and the marrow space is bigger, the pain of the insertion and the flush and infusion is much less than the tibia. In a conscious patient, you should prefer the humerus over the tibia. Much less painful in the humerus than the tibia. And there's no risk of compartment syndrome. One of the major complications of intraosseous access using any device is infiltration of the fluids into the soft tissues, which may lead to compartment syndrome. There is no risk of compartment syndrome in the arm, so the proximal humerus has that advantage. As I mentioned, flow rates are better in the humerus. In the tibia, you get 1 liter an hour, the humerus 5 liters an hour. This may vary among patients, but remember that flow is very important. So if you have an IO line that's not working, the first thing I do in my practice, in my hospital, when an ambulance comes in, they have an IO device inserted. If it's not working well, the first thing I do is I flush it very well, because sometimes the paramedics will not have flushed it adequately. In order to illustrate how quick the drugs and fluids enter the central circulation, I volunteered to have the IO put in my humerus. This is me. I wanted to feel how much pain was involved with the insertion, and it really wasn't that much pain. But more importantly, I wanted to show how quickly anything put into the humerus may get to the heart. Most of the physicians I speak with, not only in the United States, but other parts of the world, when I've done talks about IO access, physicians find it hard to believe that anything you put in the bone will enter the heart in 2 seconds. So I'll show you in this video. This is real time. Injection of contrast. Contrast in the subclavian within 1 second. Contrast in my heart within 2 seconds. This is real time. This is the epinephrine. This is atropine. This is your norepinephrine. This is blood. This is saline. Anything you need to give that patient will get to the heart as quickly and as well as it will if you were to take 20 minutes to put a subclavian central line in that same subclavian vein. That subclavian vein, by the way, is very difficult to cannulate when the patient is in shock. That vein will be collapsed because the patient is hypovolemic. The patient has low blood pressure. So this vessel is difficult to find in a shocky patient. So I urge you as clinicians to think about using the IO early on to stabilize the patient, resuscitate the patient, give them some volume, and then later on they can have a central line inserted more safely. I think I have one more video here to show very quickly. You have to be careful with these drills, they're very dangerous. Just wanted to make sure you're still awake. So let's talk about pain very briefly. A lot of people, how many of you in the room have inserted an IO into a patient before? None of you? So many of you may have misconceptions about the pain. A lot of people are afraid to put an IO because they think they hear the drill and they think this is very painful, this is very barbaric, this is torture, this is cruel to do to our patients because it's a drill, we're drilling through the bone. And this is false. There are two types of pain. There are the pain sensors, the somatic nerve fibers, so the sharp pain. And when I had the IO inserted in my arm, the pain was about a 2. It was a sharp poke through the skin, much like a needle when you're having multiple IV attempts in your arm. So it's very quick, very short, very sharp pain. That pain does not need to be alleviated with lidocaine, by the way. You can insert the IO needle through the skin. It does not cause that much pain to go through the skin. The pain comes from the pressure sensors in the bone marrow. When you insert the saline and flush, that pressure will hurt. And for me, even after giving lidocaine to the patient, and we give lidocaine once the IO is inserted, you anesthetize the bone marrow space. You're not putting lidocaine in the skin. So we put the insertion of the needle in, the lidocaine to anesthetize the nerve endings. And then, even with the lidocaine, for me it was about a 5. From the 0 to 10, the pain was about a 5. So it's uncomfortable, but it's not unbearable. When the patient is critically ill, this is something that we need to do for the patient to help save their life. So the pain is something that can be overcome. Complications are very rare. Roughly 1 in 100,000 complications with IO access with the easy IO. A lot of people worry about this compartment syndrome. There's only been 4 cases of compartment syndrome in the easy IO literature. Those are due to patients who had multiple easy IOs in the same bone. Osteomyelitis very rarely happens. There's only been 1 case reported of osteomyelitis with the easy IO since it was incepted. Central lines, as I mentioned, have their place, but safely putting a central line in takes time, and it may delay treatment of that patient. So if you have someone in septic shock, someone having a myocardial infarction, someone suffering from stroke or other emergencies, taking the time for a central line may delay their care. If we're putting a central line in a hurry, we have more risk of infection, bleeding, pneumothorax. You have to have a nurse present. You have to have an x-ray to confirm placement. And you may use ultrasound guidance, but that may not always be available. One interesting study I'll point out is, which was very thought-provoking, is this epinephrine study we've done on swine. We had 3 groups of pigs. One group got, this is a treatment of untreated ventricular fibrillation. So we simulated cardiac arrest. We had one group of pigs who had epinephrine given in the IO early on after 1 minute of CPR. And we had another group with epinephrine given intravenously through an IV after 8 minutes of CPR. and then another group who had no epinephrine. This is the result. Both the patients who received IO-access and IV epinephrine had high rates of return of spontaneous circulation, but only the early IO group, 90% of the early IO group survived 24 hours, compared to 60% of the other, the IV group. None of the placebo groups survived 24 hours or survived with good neurologic outcome. Of the ones that survived with good neurologic outcome, the ones that had IO and early epinephrine did much better. 60% did much better than the IV group. So this, in my mind, is a good illustration of how epinephrine given early on in cardiac arrest may actually be beneficial. It's something that may require more study, but we have noticed that we know that there is a study that recently came out that talked about epinephrine not being that helpful with cardiac arrest, but given early in the cardiac arrest, I think that it's possible it may still have a role. So one patient I had in my emergency department who presented unresponsive, the ambulance brought the patient, there was no IV, and is it no more time? Okay. So I'll skip through, there's no case scenario. I had a case scenario basically where patient in hemorrhagic shock and no IV, we put an IO in, I was able to establish an airway and get blood and intubate the patient. They got a central line and the patient did well. It's something that I think anytime you have a patient in shock, you should think about early on and not use this as a last resort. Think about stabilizing the patient with the IO. Thank you for your time. Arigato. I'll entertain your questions.